Good evening, everyone, and welcome to this launch hosted by Between the Lines Publishers of the new book by Margaret Keith and Jim Brophy entitled Code White. We're glad to have you with us this evening, and I'm going to begin by giving you a sense of what we'll be doing tonight. First, I'd like to acknowledge that I'm coming to you from the territory of the Three Fires Confederacy of First Nations, the Ojibwa, the Odawa, and the Potawatomi, and it was also a region on the Underground Railroad. So I'd like to welcome all of our panelists and welcome all of you joining us. We're going to start off the evening with introductions from our panelists, and we'll hear from David Gray Donald from Between the Lines about the publishing company and about the book itself and how to get it. And then we'll be going on to hear a little bit of a presentation from each of our panelists, and they will have introduced themselves to you. I will be asking some questions of them, but we'll give you as audience members an opportunity also to ask questions. And so you can send those to us in the Q&A function of this webinar or through the chat, and we'll do our best to get to those once we're through the formal presentation. So keep an eye on any notes from us through this if need be. But for right now, I'm going to pass it over to David Gray Donald from Between the Lines.
Thanks, Jane. I'm really excited to be here and to be launching Code White, sounding the alarm on violence against healthcare workers with you all tonight. So I'm Dave Gray Donald. I'm the publicist at Between the Lines. And Between the Lines is a Toronto-based publisher in Dish with One Spoon treaty territory. And we've been publishing radical books since 1977. Lots of great feminist books. In the spring, we published Karen Messing's Bent Out of Shape, Shame, Solidarity, and Women's Bodies at Work. Fantastic book. Actually, it's the UK launch for that book is happening next week. You can tune into that. We've had lots of other great books. Just another one, for example, we published the writings of Andaya, who's a very prominent, famous Caribbean activist and scholar, very important in the Black sort of scholarship world, Black feminist scholarship. And we have lots and lots of great titles. You can check them all out at btlbooks.com. And I'll drop the link to buy Code White in the chat as well. You can also find Code White in North American bookstores and libraries. If they don't have it, ask them and make sure they do have it. Support your local bookstores, support your local libraries. And if need be, you can buy the book from our web store. That's it for me. I'll get it back to Jane, but actually I should introduce Jane. So I'm gonna just read a really short bio. So Jane McArthur recently finished a PhD at the University of Windsor. She is an award-winning storyteller, researcher, advocate, and activist. She's working as the Toxics campaign director with the Canadian Association of Physicians for the Environment, known as CAPE, and is a founding member of the community-based environmental justice group Windsor Essex on Watch. Jane's dissertation research exposed how a group of women workers with high rates of breast cancer struggled against power inequities in their actions for prevention. And with that, back to you, Jane.
Thanks, Dave. So that was a little bit about me, but I'm going to actually tell you a little bit more about me just because it's relevant to what's happening here this evening. I was honored to be asked to moderate this evening's event. I actually did moderate Karen Messing's as well, which was fantastic. But I'm moderating this event for this book that is written by two people that I know very well. Margaret Keith and Jim Brophy are my parents. And so I've watched their work throughout my lifetime, and I've had the honor of working with them. And then even recently with Michael Hurley, who's here with us this evening as well, who has written the foreword to this book. we did some work together around trying to organize an international response to what was happening with healthcare workers through COVID-19. So with that, I'm going to pass it on to my folks, Margaret and Jim, and then on to Michael to do a little introduction about themselves and about what we're here for this evening. So Jim, I think you're going to go first.
Okay, I should thank people. Yeah. So I think most people, I have no idea who is listening to this, but I assume that many people who are have been activists in movements like Margaret and I have been for many years. And one thing we know about being an activist in a movement is that we never do anything alone. We always do things in a community, and that all of our efforts are amplified by being together. And so Margaret and I just want to start very quickly by just acknowledging that while our names are on the book as authors, we certainly didn't do this alone. First, we want to thank and acknowledge the scores of healthcare workers that talked to us, that did so under what are for them very difficult conditions. Not only did they tell us stories that were very painful and very moving, but they also did it in an environment in which the fear of reprisal was very strong. And in spite of that, they told us what was going on in their workplaces, shared that with us, and opened our eyes to something that we didn't know existed. So we really want to honor them and hope that we've accurately captured their experience and contributed to their fight for justice. Secondly, we want to start by acknowledging Michael Hurley, who's the president of OCHU, the Ontario Council of Hospital Unions, CUPE, who collaborated with us, who gave us the opportunity to be a part of all of this. He's been a close friend and collaborator for some decades. We consider him the most progressive labor leader in Ontario, but more than that, for us, he's helped to restore our faith that working conditions, occupational health, workers' rights can be central to being a part of a union. We also, besides Michael, we want to mention Sharon Richer, Secretary Treasurer of OCHU, that helped us throughout this project. We want to mention Linda Claiborne and Heather Nizer, who were research assistants with us. They helped organize focus groups and interviews and guided us in many, many ways. We want to acknowledge and thank the OCHU executive for supporting this whole undertaking. And then we want to really say, a big thanks to Between the Lines, to David, who already has spoken, to Amanda Crocker, to Devin Clancy, to Karina Palmatesta, and to the copy editor, Tillman Lewis, who improved our book and made us feel really that this was such an important undertaking. And then finally, I want to thank Craig Slayton, the editor of New Solutions, who guided us and mentored us through the three studies, the three peer-reviewed studies that are the basis of this book, and just really give a shout out to New Solutions for how much they supported all of this effort.
And I'll just add that Jane's not only moderating and is not only our child, but she was with us through the entire process of writing this book. And we were very grateful for all her ideas. And I don't think we could have done it without you, Jane. So I'm going to read if we were at a book launch and we were at a bookstore, we'd be doing a reading. So I'm going to just give you a few little snippets. So here are a few things that we heard from healthcare workers. On a daily basis, I am hit, punched, spat at, sworn at, slapped, bitten. I've had hot coffee thrown at me. I've gone home with burns on my hands. Another one said, I was just fixing his shoelace and he punched me in the back of the neck. I didn't see it coming. I put his pajamas on and I went to tie them. Then I saw his fist. Oh my God, here it comes. Pow, right in the mouth. It cracked all my teeth and broke my nose. And a psychiatric nurse told us, I have a stab wound right here in my arm. A patient on a medical unit who wasn't getting a cup of tea when he asked for it stabbed me in the arm. I had my ribs broken when I was working in the emergency room of a hospital, and I was put through the wall because a patient didn't like being told he would not be given drugs he asked for. I've had my legs severely broken. I've also had a chunk of flesh bitten from my body. I've had my head wrung, my jaw twisted around. I've had my family parts assaulted on many occasions. So we really believe that the book we're launching today tells a story that really must be told. It reveals secrets that the healthcare industry and the government really don't want us to know about. After speaking with hundreds of nurses, PSWs, kitchen staff, cleaners, and other allied staff, we learned that healthcare workers are suffering in silence from overwork, exploitation, burnout, lack of respect, and from violence perpetrated against them by their patients, residents, and from family members and visitors. Remaining silent is not their choice. It's imposed upon them by employers who threaten to discipline or fire them if they talk publicly about their suffering. And to add insult to injury, literally, they often feel blamed when they're assaulted. We heard this from one of the nurses we talked to. If you do report, the first thing they ask is, how did you trigger the resident? Did you provoke it? What did you do to make this happen? What was your approach? Don't you think that they perceived you to be aggressive, rushing in? But I've only got 2 minutes to get the person up and ready. And as we said in the book's preface, we completed this research, the research for the book and most of the writing just before the pandemic hit. And we've learned, not unexpectedly, that the problems that we had learned about during our research have only become worse since COVID. Hospital and long-term care workers had been facing serious challenges before the pandemic. Already overworked, burned out, and demoralized, they now found themselves in the midst of a full-blown occupational health crisis in a system that did not have the resilience or resources to meet the greatly increased needs of patients, residents, or the people who care for them. COVID has created a crisis for healthcare workers, both in terms of their protection from the virus, but also the further degradation of their working conditions. Increased staff shortages, stress, and patient and resident frustration have led to an even greater risk of violence. Unfortunately, addressing the problem of violence seems to have taken a backseat to other COVID-related problems. And I was thinking about this in terms of all the cases of cancer that are now being diagnosed at a much later date. There's so much that has been set aside during COVID that we really need to be focusing on, and that includes violence against healthcare staff. So I think we'll hear from Michael.
Thank you. Thanks very much. First of all, I'll just say I'm speaking from the traditional unceded territory of the Algonquin people. And I've had the privilege of working with Margie and Jim since the 1980s. And we actually began our connection when the health and safety movement was effectively being co-opted by the state and really gutted in terms of its ability to defend working people in a meaningful way. And what I love about Jim and Margie really is how incredibly principled they are, both of them, and they have never been afraid of standing up to industry. They have never been afraid of standing up to unions or government, employers. They have tried to give a voice to women working in plastics, people who work in customs at bridges, or the women who are working in hospitals and long-term care. There's a river of suffering that runs through this book, and they've been able to articulate it, and I'm incredibly grateful to them. They're brilliant researchers, they're popular researchers. They really do believe they have integrated into their model, I think, the kind of methods which have been used in popular education. They really refined those and made them unique. And they're also, in addition to doing what I think is groundbreaking original research in health and safety that really shakes the foundations anywhere they turn their attention. They have also been incredibly talented at making sure that these papers or books have not simply gathered dust, but have been, downloaded, read by tens of thousands of people. They are among the most widely read health and safety researchers anywhere in the world. And, I would just say on behalf of the people that we represent about 35,000 hospital and long-term care workers in CUPE, that we're incredibly grateful to them for the work that we've been able to do together around violence, but also around access to protective equipment during COVID. And you'll find perhaps tonight as we go on that there are some very significant connections between what happened to people during the pandemic and what happens to them with respect to violence. And I hope that we can get to that, because as they explain in their book, what's underlying the problem of violence, what's underlying the failure of these workers to get protective equipment during COVID is really a toxic, misogynistic, patriarchal, hierarchical work environment where workers are disrespected, bullied, coerced, and made to work at a superhuman level in order to fulfill the fact that provincial and federal governments have been engaging in underfunding and understaffing of their services for years. And in fact, in Ontario, we have the lowest level of staff to patients of any country with a developed economy in the world. In long-term care, we're second in the country. And I think they tell this story and the effects that it has then on anxious family members and on patients who are going out of their minds trying to get service from staff who are dwindling in numbers and who are overstretched. So I'll stop there. Thank you.
Well, thank you to all three of you. And it's so clear just from listening to each of you speak that you are all bringing a level of passion and concern and a real cry for action is coming out already. And I think that, Michael alluded to this to some extent, that the advocacy piece is there. It's not just about the research, the advocacy is there. And so I'm going to start by asking Jim a question, but of course, any one of you can come in on this, and happy to have this be conversational, of course. Jim, you talked a little bit about how this work gets done, because of the efforts of a lot of people, and certainly that's been the case with this research and what's behind this book. But I want to take you backwards a little bit through some of the projects a little bit that Michael referred to as well. That you started off as an occupational health researcher in many ways out of the experience in Windsor, Ontario, with asbestos workers, with women who are plastics workers. You did, a lot of important work around the problem of cancer among different workers, different groups of workers with varying exposures. And in the course of some of that work, you faced a lot of criticism and scrutiny because the advocacy piece was challenged, as though somehow you couldn't be doing this kind of work and this kind of research and be an advocate at the same time. And so I guess I'd like you to tell us how, through that long journey of all of those different kinds of occupational health and safety issues and the different workforces, how did you arrive at this problem of healthcare worker violence? And did that earlier work prepare you for what you found? And or was there something new that you learned after 30 years, 35 years doing occupational health and safety? Were there lessons here? Was there something that you can tell us about those decades of work that comes out in this problem of violence against healthcare workers?
Well, I think that's a very interesting question. And even though we're very closely related, I didn't know you were going to ask me that. I think it's a very insightful question. For me, I first started involvement in occupational health in 1979 when I read in the Windsor Star that the workers at the Bendix automotive plant in Windsor were concerned about cancer among their members after working with asbestos. And at the time I was working for the Ontario, BC OPERG, and we were doing a project on asbestos. And in truth, I have to say, I wouldn't know asbestos from anything else when all of this started. I really didn't. I just knew that it could cause cancer and that it was very dangerous and the workers were dying from it. And so what came out in that experience was that the government had known about this for 10 or 15 years and had done nothing about it, including not telling the workers that it was so dangerous. They had issued orders to the company and never enforced them, come back a year or two later and reissue the orders that they never enforced. And this all came out because there was a meeting with the compensation board and they were saying, well, we've been watching this plant for years and this, we expected something like this. And it taught me a great lesson, which is that workers' experience is valid, that it tells us something, that they actually know their workplaces better than anyone else, and that what they have to say about these issues is something really important and worth listening to, and the consequences of not listening to it can be very dire. And so, and this is where actually, Margaret and I met, and it was through this work that we've been doing, since then. And that went on and on in our experience, in organizing community or information service in Windsor, working on cancer in industry, in the auto industry, women in the plastics plants who came in, with noses that wouldn't stop bleeding and all kinds of issues. Over and over again, we learned about the experience that workers had and how valid it was and how their concerns were not being addressed and how the government ignored them. And we found this again when we were in Sarnia, both with the asbestos epidemic and also what happened with the Aamjiwnaang First Nation who were fighting the chemical pollution of the fossil fuel industry in Sarnia. And so when Michael first approached us to ask if we would assist, and we heard the stories from the healthcare workers, we were shocked by it. We, in fact, after 30 years in occupational health, we had never really heard about this. And when we heard people talking, it was like disturbing, beyond disturbing. And so, and I'll just end on this point. When we were doing focus groups, and we were sitting with groups of workers, healthcare workers, and talking to them about violence and their working conditions, and the session was over, Marg and I looked at each other and said, how was it possible that we didn't know about this? How outrageous what we were hearing was. And the reason we didn't know about it, the reason the public doesn't know about it, is that these healthcare workers face reprisal, the fear of firing, their jobs, yes, their jobs can be taken from them if they speak out on this issue. They have been abused and attacked to the point where now violence is become a part of the job. And we don't know about it because it's been kept completely under wraps. Sorry, we had a little interference there. Our puppy has decided to act up.
And I think I just want to add something about the fact that we do unabashedly call ourselves advocacy researchers. And it's become somewhat more acceptable to do that in the last few years. But when we first started out, I remember taking courses in epidemiology and being told, you must be objective. You can't have an opinion about this. You certainly can't speak about any of your findings. Write up your findings, get them into a journal, but you cannot be advocating, because as soon as you do, you're going to lose credibility. You're not going to be, the unbiased objective scientist anymore. And we just couldn't do that. We could not gather that information and just sit on it. I mean, we really have felt that we have had an ethical obligation to speak out about what it is that we're learning. What's the point of doing this research if you're not trying to change the conditions that you're finding out about? I think that that's something that there's been progress made in this in the last few years, and it is a term that people are embracing much more than they did at one time. And thank goodness.
Yeah, thank you for adding that in. And I think it ties nicely to what I wanted to raise as a question for you, which also picks on something that Jim said earlier, and Michael alluding to the methods that you've employed. So the method for this book was to gather the stories of the healthcare workers in their words, giving voice where they have been silenced. And I know that this is something that you have done for decades, and it was the subject of your PhD dissertation, participatory action research, and the importance of the people that you are researching as collaborators in that process. So I'm wondering if you could talk to us about the value of these stories as opposed to just the numbers that tell us how many times a worker was punched or how many incidents of violence. What is it about these stories that helps us to understand the severity of this problem and the need for the advocacy that you are all engaging in?
We have done quantitative research back when. We much prefer doing qualitative. It just, I feel that we understand the workplace so much better by digging into the lived experiences of the workers, asking them what it is that they are actually seeing and smelling and hearing and experiencing at work. Just to go back to the example of the plastics plants, we knew from breast cancer research we had done that women working in plastics injection molding plants, especially automotive plastics, were experiencing cancer at a much higher rate. They were being diagnosed with breast cancer at a higher rate than other people. And we had those numbers, and we looked at industrial hygiene reports that had been done and what the air measurements were, how much, acrylonitrile was in the air and this and that, but it still didn't really explain to us why they were getting sick and what was it that they were actually being exposed to. So we decided we were going to talk to them, and we held a series of interviews and focus groups with plastics workers who drew pictures for us of what a plastics injection molding machine looked like, and told us where they would put the pellets into the hopper and where it would be heated and where the vapor could be emitted, and then what would happen when they had to purge the product. They'd throw this melted smoking plastic onto the floor, and their eyes would be watering and their noses would be bleeding, their throats were sore. They knew when a product was changed, when a different pellet type was put in because there was a different smell, they felt differently. I mean, it was so eye-opening to actually talk to them, to listen to them interact, to understand what it looked like and felt like to be in one of those plants. And we understood so much better why it was that they were being diagnosed with breast cancer at a higher rate. It told the story the way that no numbers really could. And just to go back to the issue of violence against healthcare staff, we know that, that I think it's 65% of healthcare workers in a poll that was done with long-term care, and this is an OCHU poll, said that they regularly face sexual harassment. 44% that they had been sexually assaulted. Okay, those are disturbing numbers, but what do they really mean if you don't talk to the workers about what that's like? We interviewed a woman. She was part of a focus group. She was a PSW working in long-term care. She had taken a man who was strong, fit, in his 50s, with mild dementia into the shower room. She was alone with him. The door was closed and he attacked her, pinned her against the wall, started sexually assaulting her. She fought him. She screamed. She tried to get help. Nobody could hear her because there were not enough staff and there were not enough precautions in place. She was jammed up against the towel bar. He grabbed her crotch. Anyway, I won't go into the details, but she managed to distract him enough to get away, to get out of the room, went to the supervisor, talked about what had happened, and the supervisor said, wow, you were lucky, it could have been a lot worse. She was completely traumatized by the event. She asked to go home. The supervisor said, I'm sorry, we're short-staffed. We just can't. Can't you hang in there? She managed to hang in for a little while and then finally said, I can't. I have to go home. I was almost raped. I was sexually assaulted. I need to go home. She ended up taking a few days off unpaid. There's so much to that story. But, I was crying listening to it. Every woman in the room that was there was crying. People were coming up, giving her Kleenex, because she was crying, supporting her. Story after story after story like that. That's what, that 44% represents is a trauma that these people are experiencing and being told to just shake it off and get back to work. So I think, hearing those stories, hearing those voices talks to us in a way that numbers never could. Now I'm upset. Okay.
Understandably. And I want to turn to Michael from there and on this, on being upset and the emotion behind all this, because Michael, as I was watching my screen, as each of you were doing your introductions and my mom was reading excerpts from the book, I saw you shaking your head. I could see the pain in your face. You're the head of the union that represents these workers. You're behind, this research being done and this book being written to get these stories out to the public in a way that is readable and understandable. And so I just wonder if you could tell us, even today, you're obviously upset and it is terribly upsetting and it is wrong, but I wonder if you could tell us what's that experience for you, seeing all of this in print, and what do you hope to see? What needs to be done, even from the perspective of the union, for these workers?
Well, I mean, first of all, I'd just like to say that, the research that's being done here by Jim and Margie, it builds on foundations that, like, Pat Armstrong, who's joined us tonight, and her partner, Hugh Armstrong, have done great work on exposing this as well. I would just say, on a hopeful note, I think one of the great things about the pandemic has been that healthcare workers were able to hear, perhaps for the first time, for those who aren't doctors, the extent to which they had public admiration and appreciation. And, this working environment that Margie and Jim are describing, like, who would think that, an environment where like 90% of racialized workers experience racism, 44% of frontline workers are sexually assaulted, like 80% are physically assaulted once a year. And that's what happens to them. But then, if they report it, typically the response is, what did you do wrong there? You messed up, right? If they're beaten badly, and I know this from two experiences, we had to engage lawyers to get one person their job back. They, if you're beaten to a pulp and you are disabled and you're slow to recover, they want to throw you in the garbage. The bullying and coercion and intimidation that goes on around these issues, including stifling people who want to speak up about it by firing them, by disciplining them, by threatening them. You know, in the course of our research, 3 of the people that we worked with here, who are mentioned in the book, have been fired, right? Like, I think we have to acknowledge the extent to which what goes on in these institutions replicates what goes on in Canadian society, which is the experience of women, which I'm not qualified to speak to, but I would say, like, from reading the brilliant articles the Globe did last year about it, the experience of women with the criminal justice system, with the police, with, you know, reporting sexual assault, for example, right? This is the same experience happening inside these institutions, right? So, you know, what I think is hopeful is if we can name this, if we can talk about it the way Margie and Jim are doing, you know, with a workforce which is perhaps re-energized. And I think you see that a little bit in the extent to which people are leaving the healthcare professions. They're just not putting up with it. They're just walking out the door. The fact that their incomes are going to be cut in real terms to inflation for 3 years. In Ontario, in Alberta, rolled back 4%, then 3 zeros, which is like a 9% cut on top of the 4% rollback. Like, you know, in addition to all of this, in addition to not being able to bargain psychological counseling or anything else, there is coming a point here, I think, where the workforce asserts itself. I think that is where we're coming. We're not there yet. We're not there yet. And a book like this is an important step in the process of getting there, though, because it asks how, in a civilized, wealthy society that prides itself on its, you know, on its liberal traditions and its, you know, democracy, can these despotic work environments where this kind of crude, toxic, violent behavior happens to individuals systematically, how can that go on? And so I think it's in that way, it's a great service.
I want to pick up on that. So the question you just asked, how can that go on? So often we hear the response to, you know, bringing these kinds of problems is that the system is broken. Is the system broken, Jim, Michael? Is the system broken, or is this baked into this system? You know, where you've pointed out that this is about patriarchy. There's racialization here. There's, you know, inequality. So what does this say about the system, the healthcare system, and the broader system that this is all happening in?
Well, I think that's a very important aspect of all of this, that violence that's been tolerated, that has become so widespread, so ubiquitous in the healthcare system, has now been normalized to the point where it's considered just part of the job. And institutions that could tolerate that kind of situation have some very, very serious contradictions in them. And we heard that. I you know, both Marg and Michael have alluded to, or said it explicitly, you know, 85% of the workforce are women. In long-term care, the majority are racialized or recent immigrants. They suffer high rates of abuse, physical and psychological, sexual, racial abuse. We mention it and documented in the book. They experience the fear of reprisal, the fear of speaking out about it. The parallel between violence against women in our society and what we heard is so strong, it was undeniable. So this is a situation of where social class, where gender, where race, and the lack of power are so in your face. And what disturbs me, when the pandemic began, one of the first things that Marg and I said, and we talked to Michael about this, was our fear about what was going to happen, particularly in long-term care. because we had just finished the study on the conditions in long-term care, which we titled Breaking Point. The level of abuse and lack of support, the underfunding, the understaffing, people working part-time hours in different places, in order to get a full-time salary, the complete absence of regulatory controls, health and safety committees that didn't function. The Ministry of Labor was nowhere. The workers were about as angry at the workers' compensation system as that they were at their own employers. The frustration and the demoralization, people reporting how they cry in their car after a shift because they're so upset they couldn't give the kind of care that they knew that people needed. And as they described their work, it was like you were describing an assembly line operation. It was unbelievable for us to hear what was going on. And under those conditions, thinking about the pandemic, it was clear that the lens of violence shone very clearly what was going to happen there. And it wasn't a shock that so many healthcare workers became infected, such a high rate of infection, that so many of the residents were adversely affected, and even thousands died from what happened. And it was described in the Lancet as a Canadian national disaster, disgrace, what happened in long-term care with the privatization of the system and so on. So I think looking at the lens of violence, one can see how the system operates, how it's been functioning, how it's really set up in many ways, I think, to become more and more privatized. I mean, it's a very serious situation we have in our healthcare system. And we should listen to this very clearly. If we care about maintaining a public healthcare system, we must address these issues.
And maybe I'll just add that, speaking of Dr. Pat Armstrong, we borrowed the lens that she used for a lot of her work, which is feminist political economy. And, she talks about health. She says, quotes, fundamentally related to the distribution of resources and power, which in turn are linked to gender and race, in short, to the political economy. And one of her colleagues, Dr. Banerjee, was saying that violence against healthcare workers is really violence against women. The way it's being handled is very characteristic of the way society handles violence against women. We tend to overlook it, we ignore it, or we silence women. They're not encouraged to talk about it, or they're blamed. And I think we can't, we have to have gender and race and social class in the equation when we're trying to understand how it is that this group of workers has been allowed to become so exploited. And I mean, that's part of it, right? I mean, this whole mess that our healthcare system is in right now, it's been, the system has been eroding over several decades. And a lot of it, of course, is because of neoliberalism, and the privatization issue. Public funds, shouldn't be going into healthcare. We should be paying for healthcare. I mean, there are people who argue that it should, we should have a two-tiered system, or largely even a private system, which goes so completely against the creators of this precious universal healthcare system that we have. And I mean, it just feels like that this is an intentional erosion, so that we all throw up our hands and say, oh, I can't wait 12 months for a knee replacement. I'm in pain, I'm disabled, I can't work. Okay, there's a clinic down the street where I can get in, I can pay, I can get in sooner, I'll do that. And it does seem like that this is the plan. I mean, we can't say that for sure, but Ontario it's in terrible shape, really the worst province in the country in terms of beds and staffing and healthcare availability. And it does seem like it may be getting orchestrated.
Okay, thank you for that. Michael, I don't know if you want to add anything to that. And if not, I'm going to move actually to try to pick up some of the questions from the audience. Anything, Michael, to add there? No? Okay. So I'm going to pick up on Dorothy Wigmore's question about the front cover. She's noticing the body map on the front cover. And maybe you could just briefly explain for those who don't know, what is body mapping as a tool for doing occupational health and safety research? And what is it that we're seeing on the cover of this book, and how is it relevant to the violence that healthcare workers have faced in the stories you heard?
Well, really, we need Dorothy Wigmore to answer that question. She introduced us to body mapping decades ago. We adapted it for research purposes, for doing data gathering. And we've used it in a number of studies. We didn't use much mapping in the acute care study that we did, but we decided that it would be a good idea to use it partly as an icebreaker and also as a data gathering tool when we were doing long-term care, because we found that when we were doing the acute care, it was a little difficult at first to get people to feel comfortable talking. There was the whole issue of their fear that they would be found out. It's also very difficult to talk about some of these issues. It can be very emotional. I mean, we had people who were very seriously hurt. Some of them would never go back to work again. They were so seriously hurt. So body mapping is a way to sort of get at some of the issues. We had people go up together. We had an image of the human body, actually front and back, up on the wall, and gave people colored dots and asked them to go and put dots in any area of the body where they had been affected by the issue of violence. We had a cloud over the head so that they could put in issues that were related more to mental health issues or emotional issues. And they were able to indicate the severity of the injury, or whatever you might want to call it, by, with different color, different size dots. And so we would start off the session having everybody go up together, put their dots on. So that got them talking, and they were sticking the dots on, talking to each other, came back to the table and would say, okay, who wants to start? Do you want to talk to us? Anybody who feels comfortable? Tell us what those dots are. And that's when we started to hear stories like some of the ones I was reading at the beginning. And so it was a great way to sort of get things started, and then to bring out the stories. We could pick up on they'd give the example of having had their wrist broken. Well, how did that happen? Why did that happen? What happened to you afterwards? What kind of support did you get? So it was a good way to get the ball rolling. Plus that visual image, to see the human body up there. We actually did that at one of the OCHU conferences where we had 200 people. We had massive body maps. 200 people go up and put dots on. Oh, what an indictment of the healthcare system, that it was not able to protect healthcare workers from that kind of injury. The extent of the injury, the number of injuries from violence was just, it was breathtaking.
Just to mention that, we've used this technique in many workplaces, and it has a very profound, and sometimes we include other aspects of it, like hazard mapping and in your, what we call developed in your world mapping and so on. We did it with gaming workers in Windsor and in Manitoba. We did it with asbestos workers at the Holmes Foundry in Sarnia. We did it with plastics workers. We did it with women working in agriculture. But one of the most profound experiences we had with this is we were asked to go to Brazil, where a coalition of unions in Brazil were looking for a method to try to document occupational health issues, because it wasn't part of the union tradition to work on these issues, and the government was very absent. And they were very concerned. They came from very diverse areas. And they had a program called Viva. And we came in, and they asked us to come. And so we showed them what we were doing. And then there was like a psychiatrist and a university-based researcher. They both made programs, and it was all going on in Portuguese. And we had a Portuguese translator sitting next to us, and we were barely keeping up, but we could say, wow, there's some kind of dynamic tension going on here over all this. And what was
These
going
were
on?
competing methods. So we came to talk to them about how we thought they could use this method to do research. And then these other researchers had been brought in to talk about how their research, maybe they get the university to do a survey and so on.
Oh yeah, they were very high powered. And what was
they
going
picked us.
and what happened in the discussion, which we found out after, we were telling the other two that forget it. We want to have something we can control. We want our experience to be at the center of all of this. They went around, they went everywhere in Brazil. I mean, street cleaners were doing these exercises on the back of trucks after cleaning streets in Rio de Janeiro, agricultural workers. And then they took it to Africa, they took it to India, they took it to Mexico, they went into other countries in Latin America. It was the most unbelievable experience. And it taught us a great deal. And they were well-schooled in popular education. And it helped us when we started doing this work. We brought some of that, their influence and their passion for all of this and how they did it to this process.
And I think besides the voices, I think having this visual image, also there's meaning in all of that. And I think it did help to get people talking as well.
Great, thank you. I'm going to shift gears here and move on to another question. Anne Rochon Ford has asked if either Jim, Marg, or Mike could comment on whether there are any distinctions between private and public long-term care on this issue of violence.
When we were, yes, I think that there is. And there's been studies, including, I believe, studies that were reported in the Canadian Medical Journal, that there were greater numbers of incidents of violence in long-term care that were privately owned. Certainly there was more infections with COVID and so forth in these areas. When we released our study with OCHU on long-term care, I was on a radio program in Hamilton, and this whole issue came up. And the head of the PSW, Personal Support Worker Association, said that their experience was that in the private sector facilities and homes, that there was much greater levels of violence and abuse. And I think it makes sense that what's been allowed to happen here is that the private sector is now in charge of the majority of long-term care facilities. And we should make no mistake about this, that the resources that are going into these facilities, a good portion of that, from their point of view, is going in profit. It is a sector that's making money over the care of the elderly. And the resources that should be going for elder care, which is way under what is needed and required relational care, is being sacrificed for the bottom line. And how our long-term care system was allowed to come into private hands and how it was not included under our public health care system is not a mystery, but it was a real political fight. But it is a scandal. I don't think we can rectify the horror that we've seen through the pandemic of what's happening to our grandparents and to the elderly to the elderly in this country if we don't address the issue of private ownership of these facilities.
Michael, do you want to pick up on that a little bit too?
Well, I was just looking at stats out of British Columbia where the for-profit long-term care homes are spending 49% of their revenue on direct care, and the not-for-profits are spending 59% of the revenue on direct care, like much higher staffing levels. I think that's a key here. People are, people working alone is often sets them up for assault. And the truth is that the quality of care in the for-profit and municipally owned and operated homes is superior. Family members are happier, residents are happier, staffing levels are much higher. So they're safer environments for a number of reasons. As Jim alluded, you see the lack of investment in resident care. We're talking about the spin-off in terms of the impact on the staff, but you see that unfold in Ontario and Canada, where the great majority of deaths are of residents that happened during COVID happen in for-profit facilities. The facilities with the lowest death rates are the municipally owned and operated facilities, followed by the not-for-profits. That's because so much of the money that's earmarked for the service is actually invested and spent on the service, as opposed to the for-profit facilities where there was the withdrawal of millions and millions of dollars for shareholders and management bonuses, even during COVID, even during periods of time when their homes were being taken over by the Canadian military to provide services which they should have been providing themselves. And I would just say that, just let me conclude on this note. During that crisis in Ontario, our premier said that there would be no stone unturned, that the people would be held responsible for what happened to the residents in long-term care. Like 4,000 people died, right? And you put that into context, not one died in Vietnam. Not one person died in a long-term care facility in Vietnam. That's another whole story. But there are China, there are other countries, particularly in Asia, with a much better record. We lost thousands, not a single person charged, not a single CEO held accountable. And now they're starting to give some of the worst facilities, including Orchard Villa in Oshawa, which had 70 residents die, a 30-year extension without effectively a public hearing. So this interrelationship between the private sector and government, the connection between political figures who go on then to head up these private sector corporations like Rivera and Sienna and Extendicare, et cetera, the interconnection of their chiefs of staff and lobbyists, right, is, it's sickening, really. So sorry to go on and on. Yeah.
I want to just to add one thing. We have a section in the book where we talk about the history of long-term care, how it all started from kind of the poor houses in Ontario, and then houses of refuge, and how people who were put in it lost their right to vote, and if they weren't totally disabled, they were forced to work, but they couldn't leave the facility, and these facilities were outside cities, so nobody could see them. And then anyway, there's a long history. Dr. James Struthers gave us a real insight into all of this, and there is one part of the book where this is in the 50s. The conservative government is involved, and it's the big negotiations in the 50s and 60s about whether Ontario will join the healthcare system. And there's this whole question about the long-term care facilities. And the minister, I believe it was the Minister of Health, is telling the premier, this is the quote, that for privates, the owners of private facilities are just milking the system. They don't care about anything but the money, that we won't get any of this resolved until these facilities become part of the Canadian Ontario public healthcare system. Of course, that didn't happen. The Ontario Conservatives opposed it, and so they were left outside. And that corruption, that whole relationship has been allowed. And now, as Michael was pointing out, it's just festering and worse, even in the face of the disaster that we've just witnessed through the COVID epidemic.
Yeah, and so with that knowledge of the history of how this has unfolded in the long-term care facilities, and even going back to the description of, what's the system look like within hospitals. We've gone through some of that history. We've talked about the current moment with COVID, and I'm going to bring us forward a little bit now with a question from Dale Rayasich, who's a retired RN and University of Windsor professor of nursing. And she said, yes, violence is increasing. And as a retired RN for over 50 years, it is disturbing to witness this. I fear for the future of healthcare and want to know your thoughts on how we can proceed to provide healthcare workers with the skills to address violence within their organizations. So we're bringing this back to the workers who you have centered in this book. So I don't know, Mark, if you want to begin to address this. How can we empower workers within their organizations to address this problem of violence?
There are so many barriers that need to be overcome, hurdles that need to be overcome. The workers have been so exploited, so beaten down, that a lot of them now are just, throwing up their hands and saying, nothing can be done about it. I'm just going to put in my time until retirement. Of course, there are others, there are organizations saying, no, this is, their unions and other healthcare organizations saying, no, we have to do something about this. So we do need to overcome the inertia that comes from this feeling of helplessness and hopelessness. We talk about the issue of surplus powerlessness. So you're led to believe that you are powerless. And then what you do is you say, you make yourself even less powerful because you accept that. Or you've been gaslighted to the point where you believe that maybe it's just you, maybe you are doing something wrong, or maybe you don't deserve anything better. There are so many of these psychological barriers that need to be overcome. I think one of the really big problems has been the fact that the public has not known what's going on. It's so important that we have supporters, that we have allies, healthcare workers. I'm sure, if the public really did know about this, they would have lots of support from people who would say, this is not acceptable. We demand changes. So I think building these alliances is going to be so important. I think talking about it is so important. Healthcare workers need to talk amongst themselves about it. They need to talk about strategies for overcoming it. I mean, the thing is, violence can be prevented. There is a cure. There are ways of preventing violence, or if violence occurs, preventing workers from becoming hurt. We need some of these strategies in place. We need adequate staffing. We need adequate resources. We need to re-engineer a lot of the wards, the floors. We need better communication systems. None of that's going to happen if workers are not deemed to be deserving of that kind of protection. So, this is, as we said before, one of the reasons we wrote this book is that we think it's so important that the healthcare workers' voices are heard. I mean, we've heard pleas from them. We heard them saying, being so grateful that we were doing this, but also saying, somebody's got to help us. Well, I think they're doing an awful lot themselves. And I think OCHU has been doing a tremendous job of these rallies that have been going on in the last little while around COVID. And before that, a lot of rallies around the issue of violence, helping to bring it out. But I think the coalition building and the building those alliances is going to be a big part of this. I think if the public truly understood what the healthcare workers were experiencing, they would be outraged. And also, if they understood how healthcare, the actual care the patients and residents are getting, is very much affected by those same conditions that are leading to violence. We talk to people who have been working in healthcare for 20 or 30 years who said, I used to have time to sit and hold my patient's hand or rub their backs or talk to them about their fears. There's none of that anymore. Everything's so rushed. The whole idea of care has changed. It has become a production line. And I, as a potential healthcare consumer want to think that when I go into a hospital or I go into a care facility, the care will be there for me. And if we listen to the voices of the healthcare workers, that are coming out in this book, we'll understand that that's not what we're going to get. And we're all suffering as a result of this erosion of the system.
I mean, the only thing I would add to what Margaret said is that, both the union rights and the occupational health rights of healthcare workers are truncated. And I think, I know the complications, the issues about the right to strike are complicated, but the workers have no vehicle, no method to try to impose, have a major influence on their conditions of work. And also what we found in the study, which is not surprising, that it's true across the whole of society, is our regulatory system is completely broken. The occupational health and safety committees didn't function through COVID. They didn't function when we did our studies on violence. As I said earlier, the compensation system was as much of a seen as a tyrant and as a source of the problem as their employers were. There was no effort by the Ministry of Labor to engage and demand that worker protections be in place. So our regulatory system, which is part of of neoliberal global capitalism now, to back away from any kind of government intervention into this, into the workplace. The employers are supposed to take care of these things. It's all, to be smoothed over. But in reality, this is just opening the door to tolerate the worst types of conditions and behaviors. So I think, as Mark said, the healthcare workers are bringing this story out, but they need support. And it's a barometer for the health of the healthcare system. The health of the healthcare workers is a barometer for the health of the healthcare system. And right now, the level of demoralization, the level of burnout, the level of exploitation and abuse is so high. It's really in the public interest now that the healthcare system, the issues of underfunding, understaffing, the lack of legislation, for instance, whistleblower protection for healthcare workers, the time to care, the ratio of staff to residents in long-term care, that these issues be addressed. And they won't be addressed until the public really says, enough is enough.
I want to this issue of whistleblower protection, I think, is so important. And I think the silencing of workers has been such a problem. And if they could talk openly and feel safe, I think it could make such a difference. I just want to go back to my reading a little excerpt from the book. Unfortunately, the silencing of healthcare workers about violence on the job makes it difficult for them to reach out to anyone other than perhaps co-workers or union representatives about what they're experiencing. Rebecca Solnit, who wrote a book about the silencing of women as a form of control, says, being unable to tell your story is a living death. Violence against women is often against our voices and our stories. Silence is what allowed predators to rampage through the decades unchecked. Having a voice is crucial. It's not all there is to human rights, but it's central to them. And so you can consider the history of women's rights and lack of rights as a history of silence and breaking silence.
I think that's an important note to end on, to reaffirm here that what this book is doing is breaking the silence. It is calling the code white on the epidemic of violence in the healthcare system. I wonder if maybe just a final thought from each of you. You've done such a great job of explaining the problem, the depths of the problem, the reasons behind it, the theoretical analysis of why this exists. But I wonder maybe to appease the sociologist in me who always asks the question to get to the nitty-gritty. So what? So what should we take away from this book? What can we do in allyship and solidarity to keep the voices of the healthcare workers heard on this issue of violence in the healthcare system?
Well, I'll start and then somebody else can pick up on it. But I think you have to read this book for one thing. It's an uncomfortable book to read, but I think it's an eye opener, and it just might inspire you and others to start crying foul. We need to keep talking about this. We need to talk to healthcare workers about it. We need to encourage them to speak up. Whenever we get a chance, we need to express our outrage around all of this. I mean, I think the bottom line is that violence against healthcare workers can be prevented. And so, we need the will, but we also need a movement to try to get this, that goes beyond just the healthcare workers themselves. We do need to try to see how we can come together as a social movement to try to address some of these issues that so much of it is being borne on the back of these exploited workers. And we need to do whatever we can to help out.
I had an experience at 4 o'clock, which kind of leads me to my answer to what you just asked us, Jane. I think what people should do, and Dale's question earlier, is talk to the healthcare workers that you know. Ask them if they think violence is an issue in their workplace. We haven't found anybody that has a healthcare worker that hasn't affirmed everything that we say in this book.
So what happened at 4 o'clock?
Okay, so at 4 o'clock, there's a knock on our door. We're living at staying at our cottage in Rondo, so nobody ever comes to our door. So we didn't know what to make of it. So we go, and it's a nurse. It's a big sign. He from the
Public
health unit in Chatham. He's got a sign, RN, on it, so on and so forth. Now, this is what he came for, to tell us that we're the furthest point, but within the radius of if there was a nuclear meltdown in either in Fermi in Michigan or a nuclear plant in Ohio, that we would need to take, if we wanted to, iodine tablets to protect our thyroid. And so the irony of all this is, of course, we've opposed these nuclear plants that are on the border with Canada for decades. So it wasn't news to us, but it was shocking to see that, okay, we better take care. So at the end of all this, I said, "You're an RN." And I said, "Yeah." And I said, "Well, it's funny that you're here because today we're going to be speaking about, violence against healthcare workers." And he said, "Oh, I can tell you about that. I can tell you what's happened to me." He was starting right off telling me, about incidents that have happened to him. That is the experience I've had with every single healthcare worker I've spoken to. We need to have the conversation with our friends, with our neighbors, with these folks. Let them know, first hear their stories, but let them know that we don't support that.
That's powerful. Thank you. Michael, do you want to add any final thoughts to that?
Well, I would just say, like in Ontario, we're really blessed. We've got the Ontario Health Coalition, and I think they're trying to do wonderful work. They're trying to empower healthcare workers, and they're trying to empower the residents in long-term care and support and protect patients in hospitals and in the community settings. And they're together we're looking at taking private legal action against the owners of the for-profit long-term care facilities, et cetera. There's wonderful work being done there. That would be a great place for anyone to get involved. This challenge of democratizing these institutions in healthcare is going to take a while, but that would be where I would really strongly encourage people to invest their time. That's where we invest a lot of our time as well.
Well, thank you, all of you, for those final notes. And I think you've made some really good suggestions for where to go from here. And so with that, we're going to wrap on the questions. I want to thank everyone who joined this evening to launch this book. Thank you for your questions and for the comments in the chat and in the Q&A. I want to remind everyone to, as Marg said, buy the book, read it if you haven't yet, tell your friends, as Jim had said, and we need to keep this issue at the forefront if we can to make change. So as Dave told us earlier in the call, look in your libraries, look in your bookstores. You can purchase it from Between the Lines books online as well. Thank you so much, Michael Hurley, for what you've added to this discussion tonight and for the work that you are doing to advocate for healthcare workers, not only on the issue of violence, but so many important critical issues, and for your advocacy on the healthcare system. And to Marg and Jim, Mom and Papa, thank you for this important work. Just, one of so many pieces of key advocacy for not only the workers that you have, whose voices you've brought out here, but for all of us as a society, because this is all interconnected with the kind of world that we live in and the kind of world we want to live into. So thank you for giving voice to the workers who can help us to see what we need to fix. Thank you for sharing all of that with us. Thank you for being brave enough to tell your stories through these stories. And I hope that we move forward with solutions and greater knowledge. So thank you and congratulations on this book. And thank you to everyone here tonight. And I wish you all well. I wish you happiness and health and safety and solidarity.
Thank you for doing such a great job, Jane. Thank you.
Yes, absolutely.
Thank you.
Between the Lines. Thank you, Jane McArthur.
Yes.